any fire department, emergency medical services seminars for EMS providers. Uh, Today, we have the honor of having Dr. John M. Dunford give us a talk on field deaf pronunciations for the emergency provider, which is always a difficult topic. John comes to us from Walter Reed National Military Medical Center in Bethesda, where he is a neuroanesthesiologist. He's the section chief for neuroanesthesia there. He also works with Johns Hopkins Hospital every once a week. What is it, Tuesdays?
Tuesdays, yeah.
Every Tuesday for neuroanesthesia in the main ORs. John is a diplomat of the American Board of Anesthesia and a diplomat of the American Board of Neurology. He did his neurology training with the military at Letterman, I believe, Army Medical Center, and at the Presidio, and then his anesthesia residency at Johns Hopkins. Prior to coming to us at Walter Reed, I worked with John for over 25 years at this point at Walter Reed. And without further ado, I'll hand it off to John. Welcome.
Thank you, Dr. Sago, for the introduction. Tonight, we're going to talk about field death for the emergency provider. I'm going to use the medical protocols for EMS services from the state of Maryland, and we're going to look at the July 1st, 2024 protocols. They are the most recent protocols that I have been able to anyway, I think at this point they're pretty current. Death for the EMS provider. Death in the field can be psychologically very difficult. It can be internalized as a failure of both the EMS provider and the EMS system in general. As EMS providers, we anticipate we're going to help people and save lives. And dealing with death then can be a bit counterintuitive to what we typically do day in and day out in our process of trying to save lives. So on one hand, we have an EMS system that works very hard to resuscitate and save lives. On the other hand, if we allocate these resources to patients who have expired in the field, those resources could be used somewhere else. I mean, EMS resources are very finite and valuable. EMS workers in the field are constantly in danger of accidents on calls. And these things calls are not without risk to EMS personnel. Wasting scarce EMS resources on futile attempts to save a life can take resources away from other patients that potentially could better use these resources. Death is obviously part of the human condition, and we all die. Now, tonight, the summary of what I'm going to talk about is this. When you have an EMS call and respond, you're going to check, is the patient unresponsive, pulseless, and apneic? Are there obvious signs of death, lividity? Is there a MOLST? And if you do start resuscitation, are the termination of resuscitation criteria met? In other words, is the patient pregnant, age less than 18, hypothermic or drowned, in which case termination resuscitation guidelines will not have been met. For a non-trauma, after 15 2-minute cycles of CPR or 30 minutes, or with blunt trauma, failure after 5 2-minute cycles, in other words, 10 minutes of CPR, can indicate termination of resuscitation. And lastly, with every death at the scene, we have to determine if it's socially or legally appropriate not to transport. So these are the things we're going to look into more tonight. Now, if we dive into the protocols, we can see here termination of resuscitation for the adult, termination of resuscitation for pediatrics, pronouncement of death in the field, and the EMS DNR MOLST. This component of the guidelines is what we're going to discuss this evening. Now, I'm going to go on my own code real quick. my stepdaughter here, it calls emergently, which she did because her bird has fallen into her bird cage. So I'm doing my EMS run to the bird, and I'm going to try to apply the EMS protocol to the resuscitation of this particular patient. Now, when I look at the patient, I can look at my guidelines and I can say, can I pronounce this patient dead in the field? Well, what could I do? Well, I can see if the patient is decapitated. I can see if rigor mortis is set in. I can see if the body has some decomposition. I can see if there's dependent lividity. I can check for a pulse, see if the patient's apneic, and see, are there other casualties? In other words, can I use a black tag, or am I going to black tag the patient as we would do in a mass casualty situation? Or is the patient pulsus apneic and the injury is not compatible with life? Well, in this case, I do an exam on the patient and the patient is stiff, rigor mortis has set in. So I can, in this case, pronounce the patient dead in the field. Now, the BLS provider, bear with me, will confirm the patient is unresponsive, pulsus, and apneic, document the exact time and location of the death, notify law enforcement to follow local jurisdictional policies. If this patient's an organ donor, we'll make the phone number. And if death is pronounced during transport, we will deliver the patient to the hospital. In this case, because rigor mortis has set in, I can indeed confirm the time of death. Now, let's look at what death is. Death is the irreversible cessation of circulatory and respiratory function, or it's the irreversible cessation of all functions of the entire brain, including the brainstem. So if the entire brain is not working, or if there is complete loss of circulatory respiratory function, then the patient is considered dead. Now, in the field, again, decapitation, rigor mortis, decomposition, dependent lividity, pulsus apneic patients in a mass casualty situation, and a pulsus patient, which is an injury incompatible with life, we can then, the BLS or ACLS provider, can pronounce the patient dead in the field. Now, this last component of this page says the termination of resuscitation protocol has been instituted. And again, if the termination of resuscitation protocol has been instituted, we then also can stop resuscitation and pronounce someone dead in the field. Okay. And then again, this termination of resuscitation protocol is a component of our pronouncement of death in the field. Now, if you look at our termination of resuscitation protocol, we can look and say, okay, patients who are cardiac arrest, our medical protocol, these are patients who are in cardiac arrest due to a medical or traumatic etiology. Now, there are patients that are excluded from our cardiac arrest termination in the field protocol. They are pregnant patients and patients who are hypothermic or have a submersion injury. Otherwise, the BLS provider can go ahead and pronounce death in the field with termination of resuscitation if the patient's over 18, ALS resources are not available, 30 minutes of CPR is performed, and the AED has not fired for 5 different times. So after you've analyzed the shock for 5 times. From the ALS standpoint, for a medical etiology, it's if the patient's over 18, we have 30 minutes of CPR, the patient's in asystole, or the patient is in pulsus v-tach v-fib PEA with an end tidal less than 15. Now, we're going to go over these numerous times throughout the next 60 minutes. So bear with me on this one, but I'm just putting it out there so we get an introduction. So from a medical etiology, we're doing CPR for 30 minutes. With a traumatic etiology, blunt trauma over the age of 15, if the patient's in asystole, you can terminate resuscitation. If the patient's cardiac rhythm changes to asystole during resuscitation, again, you can terminate resuscitation. If the patient is in pulsus v-tach, v-fib, or PEA with over 5 2-minute cycles of high-quality CPR, the potential is there to terminate resuscitation. And we'll talk more about this in some detail. Now, where do these come from? Well, let's look. The annual incidence of cardiac arrest is about 326,000 a year in the US, and the prognosis without return of spontaneous circulation is about 0.6%. CPR is a better quality at the scene. We know that. Transport with lights and sirens can be dangerous, and transport's expensive. So the Canadians in the late 90s into the 2000s, as I'll show you the more specific dates in a minute, started this, went ahead and did a study called the OPAL study. And what they were trying to do is say, look, should we be investing lots of treasure, time, and energy in an ALS system to take care of patients in the field? In other words, is an ALS system going to be helpful, and is it economically appropriate for these resources to be allocated? And what they did was they looked at cardiac arrest, and they determined that they needed 5,000 patients with a cardiac arrest to get a 2% absolute difference in survival. So in other words, they wanted to power it so they could look at a 2% difference in survival. For major trauma, they had another 3,180 cases, and they wanted a 3% absolute improvement in survival. For respiratory distress, they powered it for another 4,630 cases, and they needed that to detect a 2% survival difference. So this is a lot of patients. And what they found was that for cardiac arrest in phase 1, for 4,690 patients, they saw that bystander CPR saves lives. They did, and that was, they found that. It's a very important thing. Second, in phase 2, they realized that if you optimize your AEDs improve survival. They determined that. So then they went into phase 3. Over 3 years, they took a full ALS paramedic program, enrolled 4,247 patients in, and found that in addition to the bystander CPR and the AEDs, they found no incremental benefit in survival from ALS, which was interesting. And they delved into that to determine, why is that? Well, by the way, with trauma, that was for trauma, they found that if an individual severity score is greater than 12 over the 36 months, they couldn't show, over 2,884 patients, they couldn't show any benefit from ALS. But for respiratory distress, including congestive heart failure, there was a significant decrease in patient mortality. When they dived in and looked at the data, they found this. They said for BLS and ALS providers that if the victim has the cardiac arrest is unwitnessed by EMS, has had no AED shock delivered, there's no return of spontaneous circulation at the scene, and for ALS, unwitnessed by a bystander and no bystander CPR. So in other words, no one saw the arrest, no one did bystander CPR, there was no AED, and there's no ROSC, then the chances of survival are extremely low. And if you fast forward, and by the way, this is from 1999 to 2000, in that range. So if you go for 20 years later, if you look at our ACLS guidelines, the most current ones, they still have many of these same factors. If you look at the ACLS termination of resuscitation or the BLS resuscitation of termination, they both say, look, the arrest is not witnessed. Okay, there's no bystander CPR. There's no return of spontaneous circulation. There's no AED shock delivered. And according to the ACLS guidelines for termination of resuscitation, if all of these criteria are met, termination of resuscitation can occur. Now, so when, and this is as of 2020. Now, in addition to this, we can look at end-tidal CO2. In the late 90s, this New England Journal article came out, and it said that with 20 minutes of CPR, if the carbon dioxide end-tidal CO2 level is less than 10 millimeters of mercury, then that was predictive of a 100% death rate. The study demonstrates that the level of end-tidal CO2 measurement during resuscitative efforts can be a predictor of death from cardiac arrest in patients with electrical activity with no pulse. So now we have another factor that we can use to determine when we can terminate resuscitation. Now, based on this data in 2003, the Journal of the American College of Surgeons came up with guidelines for the termination and resuscitation of cardiopulmonary arrest. And they said that the primary focus still should be on evacuation of patients. EMS systems should, but EMS systems should implement protocols. Again, this is 20 years ago, that allow for termination of resuscitation in the field. These protocols should be in place and require specific CPR intervals, for example, 15 minutes to termination. And further research is required to determine the optimal duration of the CPR. They said physician oversight is mandatory. The termination of resuscitation protocol should be accompanied by procedures to ensure appropriate management of the deceased patient and support services for family members when someone has expired in the field. But again, the emphasis is on increasing the number of patients who are pronounced dead in the field and transporting less so that EMS resources could be better used. Now, if you look at a simplification for blunt trauma in particular, if you have a blunt trauma and asystole, the risk, the death rate is 100%. Blunt trauma with asystole was found to have a 100% death rate. Now, the New England Journal, and this is, you can't probably see this, it's small, but the New England Journal in 2006, I believe this was, came out with an article saying, look, the validations of these rules of termination resuscitation are in place and or continuing, but if we do apply these termination resuscitation rules instead of transporting everyone, we can drop our transport rate of these patients from a 100% down to 37.4% transport rate. And then what they did was they looked at, of the patients that were inappropriately transported according to the rules, they looked at why patients were transported, even though termination resuscitation should have occurred in the field. And if you look at the bottom, the most common reason was family distress. It's hard to leave a body in someone's house at the scene, particularly a child. Sometimes the arrest was it was a short time to arrest, short transport time to the hospital, paramedic discretion, public location, patient's age, unable to establish a phone call with a physician. There's numerous reasons why patients that should have been or could have been pronounced dead in the field, and releasing that EMS resource and not transporting these particular cases. 21% of the time, this isn't done. And these are the reasons why most commonly the patients were again transported, even though they didn't have to be transported. So let's go look at this criteria. Unwitnessed by EMS, no AED, no shock, no ROSC, unwitnessed by bystander, and no bystander CPR. And if you look at the protocols for 2016, you'll see in the state of Maryland that they've been included in these protocols. You can see the arrest was not witnessed by an EMS provider in 2016. There's no shockable rhythm. Again, these were implemented by 2016 in the state of Maryland. Now, we'll keep continuing with our Maryland protocols, and we'll look at how they're evolving to 2024 in a minute. But I also want to reinforce something about carbon dioxide. If we know that the 20-minute carbon dioxide end-tidal CO2 level, if it's less than 10, that portends a very bad prognosis. But we also know that good CPR, when you have great CPR with pulses, VTAC, VFib, or PEA, even if the patient meets the termination resuscitation criteria, with good CPR, we not uncommonly will get an end-tidal potentially greater than 20. So we can't use just end-tidal CO2 on its own as a measure of when we can terminate resuscitation. Now, by 2018, the CO2 component was added. We saw 2016, looked at the old criteria, and by 2018, pulses, VTAC, VFib, PEA, and end-tidal CO2 less than 15 had been added to the protocol. Now, and again, this slide reinforces the fact that good CPR can keep an end-tidal greater than 20. So we can't just use end-tidal all on its own. So let's go back to our protocol and delve in for termination resuscitation in the adult and delve in a little more carefully. So again, pregnant patients, hypothermic patients, patients with submersion injury will not have meet termination of resuscitation protocols and will not meet the pronouncement of death in the field protocol. If ALS resources are genuinely unavailable and the victim is 18 years or older and 30 minutes of high quality CPR has been performed and 5 AED analyses have been done prior to termination, a BLS and those analyses say no shock advised, a BLS provider may terminate resuscitation in the field. Now, for ALS, again, that's only if a ALS resource is genuinely not available. And that's pretty rare in our system, right? But for an ALS, medical etiology, if you're 18 years or older, 30 minutes of CPR, and the patient's in asystole, or over 18, 30 minutes of CPR with pulsus VTAC, VFib, or PEA with an end tidal less than 15, termination of resuscitation should occur for medical etiology. For traumatic etiology, the adult is over 15. So patients 15 years or older, and the patient's in asystole with blunt trauma, you can terminate resuscitation. Or if the rhythm changes to asystole, you can terminate resuscitation. Or if you do 10 minutes of CPR and the patient's in pulsus VTAC, VFib, or PEA, you can terminate resuscitation. Now notice, this is blunt trauma. It's not going to be a penetrating trauma, blunt trauma. Now, the clinical pearl here is that time-sensitive strategies have to be performed. In other words, the patient needs to be ventilated. If there's a tension pneumo, it needs to be treated. If there's blood loss, that needs to be managed. In other words, time-sensitive therapies have to be taken care of, and the assumption here is that they've been taken care of. Now, let's look at the algorithm. We can see then this minimum of 10 minutes of CPR, high-quality CPR, is critical for the medical arrest. And then, of course, asystole, or if you have pulsus VTAC, VFib, PEA with an end tidal less than 15. Now look at trauma. Blunt trauma we talked about, but penetrating trauma, we can see here in the blue box, gets transported. It gets transported. There isn't a determination of resuscitation in the protocol if there is penetrating trauma. All right, now let's look at children. Children, it's similar, but we have to look at the importance of epinephrine in the resuscitation for the medical etiology in a child. So BLS cannot terminate resuscitation for a pediatric patient. For a medical patient. For a traumatic patient, if there's no ALS resources, there's a minimum of 15 2-minute cycles of CPR and 5 AED analysis immediately prior, then again, a termination could occur. But for medical, it's not going to happen. And one of the reason why we might suppose is because epinephrine needs to be administered, which we're going to see here under the ALS protocol. When we look at the ALS protocol for medical, again, if a patient has received 15 2-minute cycles of CPR and at least 1 dose of epinephrine, and the patient's in asystole, and the patient has a end tidal CO2 of less than 15, and in the judgment of EMS and law enforcement on the scene, there's adequate social and emotional support and safety for civilians and professionals on the scene. In the judgment of the EMS and law enforcement, the scene is amiable to leaving a child on the scene, then again, the termination can occur. For traumatic etiology, again, 10 minutes of CPR without ROSC, patients in asystole, patient has sustained end tidal less than CO2, and then according to the local law enforcement, it's permissible to leave the child at the scene, then termination resuscitation in children can occur. And here are the flow diagrams. They're in the protocols that reinforce what we just said. Okay. Now, so we've looked at pronouncement of death at the field, and we've said that at the EMS clinician has, if the EMS clinician has terminated resuscitation per the termination of resuscitation protocol, they can, again, pronounced death in the field. But let's look at these decapitation, rigor mortis, decomposition, and lividity in a little more detail, so we know exactly what these things are. Because again, if you're going to, as an EMS provider, determine that someone has lividity, we have to know what the legal definition of lividity is so that we can implement it properly. All right, so what happens after you die? The first thing that happens is you get a pallor mortis, the paleness of death. That occurs between 15 and 30 minutes. The livor mortis, the blueness of death, the color of death, comes when blood settles in dependent areas. Desiccation occurs, which is a drying, especially in mucous membranes. They become dry. Algor mortis, the body cools. Rigor mortis, the body becomes stiff. You get eye changes. We'll show you some pictures in a minute. Then the patient has decomposition and then mummification or skeletonization. So in the next few minutes, we're going to look at each one of these so we can determine what each component of each component of the changes of death as it occurs. So first, we have the pallor mortis. Between 15 to 120 minutes, between 15 minutes and 2 hours, the blood will, by gravity, move away from the superior part of the body to the inferior part of the body. If the body is supine on their back, the face then, of course, would be pale, and the back of the head would start turning blue as the blood goes that way. Now, lividity just means black and blue in Latin. Postmortem lividity means black and blue after you died. Hypostasis is the coroner's term for is for the lividity. It just means standing underneath in Greek. And the settling of blood in the dependent portion of the body after death is what lividity is. Now, we said that this lividity, the blueness, starts in about 20 to 30 minutes. It's obviously noted at about 2 hours. It can be pink, blue, or purple. It's a maximum at about 12 hours. It increases its maximum size. And it blanches for the first 12 hours. So if you have a gloved finger on a corpse and the lividity is still blanching, you know that the corpse is less than 12 hours old. Now, these patches can move up to 3 days. Parts of the skin, and then the parts of the skin under pressure will stay white. In other words, they won't get the purple color that is associated with lividity. And let's look at some of these. These are some of the blanch areas. So when you're supine on your back, shoulders, buttocks, and heels will be pale. If you're vertical hanging, the proximal arms and legs will be pale. And that means like the legs at the bottom part of the legs and the hands, they'll be dark. With the drowning, the upper chest and upper limbs will be involved. And face down, often you'll get a white nose and lips and chin because your face will be will be compressed and the blood won't be able to get into them. So let's look at some of the pictures. This is the livor mortis, blanch area, for someone who's expired, and this is the back. Here's another area of someone who's passed away, who's been laying on their back, and this is the blanch area. Here's another blanch area. Again, you can see the buttocks and back. This is someone who has a hanging. You can see the lividity in the legs, and the legs are much darker than the lower part of the legs is much darker than the upper part of the legs. The hand, we can imagine, is a little bit darker than the upper part of the arm. Again, less than 12 hours, the lividity will blanch. And this is someone who's expired on their front, and we can see the pallor there. Dependent areas with lividity, sometimes the capillaries will break. And so you'll get these little spots where the capillaries have caused a little tattoo. Here, if you lay on something, you can see there's a little mark that we can see with lividity. Here's some youngins that have unfortunately passed away, and you can see the lividity on them, and you could determine then in what position they are when they died. The liver, the organs themselves also will have this lividity. So when you do an autopsy and look, you can see these dark areas and determine what position the body was when the person died. Now, rigor mortis. Now, if you look at the muscle has an actin filament and a myosin filament, and they have these cross arms that move. It takes a lot of energy to do this, and when the actin filaments cross link across between the myosin and the actin, these myosin heads move, And again, that's what causes muscle to, that's what helps us flex and extend our muscles. With rigor mortis, what happens is that because there's no energy substrate to facilitate the moving of the actin and myosin, the muscle does not move and it becomes stiff. Rigor mortis means the stiffness of death, and rigor mortis appears to start, or will appear, starts within between 1 and 6 hours. The first muscle that's affected with rigor mortis is typically the eyes. Because of this, it is a tradition in most cultures to close the eyes of someone after they've expired, because if the eyes are not closed within a relatively short period of time, rigor mortis will keep them open, and it's very difficult, potentially, or more difficult for the mortician to close them if indeed the body will be showed later. Neck and jaw can get stiff pretty soon. Anyway, the rigor mortis spreads to other muscles, including the internal organs, between 4 and 6 hours, with complete rigor between 12 and 24 hours. The pupils also can get rigor mortis, and you can get a cat's eyes look because you have rigor in the muscles around the eye. So decomposition is going to occur between 24 and 36 hours. And this, then, the decomposition of the muscle occurs, and then the muscle then starts to become flaccid. So in summary, if your body is warm and flaccid, it's less than 3 hours old. If it's warm and stiff, it's 3 to 8 hours. If the body feels cold and stiff, it's 8 to 36 hours. And if the body's cold and flaccid, it's greater than 36 hours. On this slide, for rigor mortis, we're concentrating on the flaccid, stiff, flaccid. Flaccid less than 3 hours, stiff 3 to 8 hours, 8 to 36 hours is stiff, and then flaccid greater than 36 hours. Now let's look at temperature. Algor mortis is the coldness of death. It may be helpful in deciding the time of death within the first 24 hours post-mortem. The body drops 1.5 degrees per hour typically for the first 6 hours of temperature. And therefore, if you take the temperature of the corpse and take that number, subtracted from normal body temperature, and divide that by 1.5, you can determine how many hours how many hours it has been since the time of death. Now, there's an interesting thing called post-mortem caloricity, in which the body actually can increase in temperature. This is seen after lightning strikes and tetanus and certain types of strokes, sun exposure, infections. These things, some of these things can actually cause the body to warm up, but typically the body will decrease in temperature at a very predictable rate. Now, what happens is once there's no fluid being made in the body, so wherever there is no skin, you'll get drying. The most common place this is going to be seen is actually on the eyeball, in the conjunctiva. The eyelids will gradually shrivel, the lips will shrivel, and again, you can get this dark patch across the cornea where the eyes are a little bit open and the cornea has become dry. One thing that's interesting, there's a special kind of spasm that occurs with death if in this case, let's say this patient had been falling off a cliff, and a victim falling off a cliff, and they're holding by a stick and they're really holding hard, and then they fall and they die. That hand now is clasping hard. Sometimes you'll see in the hand will be hair from someone that has attacked them. They'll try to defend themselves, hold on to someone's hair or something. So sometimes there's a very interesting type of rigidity and spasm that can occur right at the time of death that does not require hours to take place. Again, this is usually associated with emotional and physical stress. So body feels warm and flaccid, less than 3 hours. Body feels warm and stiff, 3 to 8 hours. Body feels cold and stiff, 8 to 36 hours. Body is cold and flaccid, greater than 36 hours. Now, let's look at decomposition and skeletonization for a minute. We said that the rigor mortis slowly goes away because of decomposition. What happens is the cells, to stay alive and healthy, have to have oxygen to make their cell membrane strong. But if if you don't have oxygen to the cell membrane, then the cells begin to die. The cells have little stomachs in them called lysosomes, and they can come open, and then the internal acids from inside the cell can be released. And the cell eventually will autolyse itself. And there are other things that happen, but nevertheless, these cells will start to die just because of decomposition. The stomach, pancreas, intestine, brain, adrenal glands are particularly prone to autolysis. So, and then lastly, we have putrefaction. And this is because of bacteria. What will happen is between 2 to 3 days, a curious green swelling on the right lower side of the abdomen will occur. So if you're called to, let's say, a hotel room or a house, and you anticipate someone's passed away some time ago, you would look, and if it's 2 to 3 days, you'll see a green swelling in the lower right quadrant of the abdomen. At 3 to 4 days, you'll see this greenness all over the chest with a marbling of the veins. If they've been in their house 5 to 6 days, you'll start to see the skin blistering and abdominal swelling with gas green, purple colors in their face. At 2 weeks, the abdomen will be very tight and swollen. By the way, at 5 to 6 days, the nails are still on, but the nails fall off at about 3 weeks. At 4 weeks, the soft tissues all begin to liquefy, and eventually the patient becomes unrecognizable. So at about a month, you won't be able to recognize the corpse. So let's look at this. So if you come in and to someone's home and they've expired about 2 days ago, you'll see this green lower quadrant section of discoloration. Then the next 3 or 4 days, you'll see this greenness spread all over the chest. At 5 to 6 days, you'll see the skin starting to fall off. And then at 2 weeks, you'll get all swollen. 4 weeks, you can't even tell what the person looked like. And eventually, one of two things will happen. Either all the meat will fall away and you'll get skeletonization, or rarely, if the corpse is in just the right environment, it'll turn to fat and you'll get a mummification of the corpse. And this is the natural process that occurs with the body after you expire. So again, we've looked at the pallor mortis, livor mortis, desiccation, algor mortis, rigor mortis, eye changes, decomposition, and mummification. So as an EMS provider, we first of all can say, yep, we understand exactly what the terminology is of pronouncement of death in the field, but also we can have some idea maybe and can be helpful at the scene for determining how long a person has been expired in their home or wherever they're found. And again, here's the list. 20 to 30 hours, the corpse starts to smell. And you can see all the different changes that we just talked about previously and looked at. All right, so we've looked at termination of resuscitation for the adult and child. We've looked at pronouncement of death in the field. And lastly, I'd like to talk about the MOLST. Now, if you look at the POLST or MOLST, the Physician Order for Life-Sustaining Treatment, in Maryland, it's the Maryland Order of Life-Sustaining Treatment. Where did this come from? In 1991, leading medical ethicists in Oregon discovered that patient preferences for end-of-life care were not consistently honored, recognizing that advanced directives were inadequate for patients with serious illness or frailty. These patients frequently required medical care. A group of stakeholders developed a new tool for honoring patients' wishes for end-of-life treatment. After several years of evaluation, this program was called POLST, or Physician Orders for Life-Sustaining Treatment. Now, in Maryland, Maryland instituted a form of POLST, which is called MOLST, the Maryland Order of Life-Sustaining Treatment. This was effective as of January 1st, 2013, so it's about 11 years old now. Prior to this, you had the EMS DNR. So, and again, old EMS DNR forms still apply, but at this point, the MOLST is a portable and enduring medical order which conveys options about cardiopulmonary resuscitation and other life-sustaining treatment. The medical orders are based on the patient's wishes about medical treatments. The order form may be signed by a doctor, nurse practitioner, or physician assistant. In the absence of a valid MOLST form, the EMS DNR or an EMS DNR order, patients calling for an ambulance service who are unable to communicate their healthcare wishes will receive restorative interventions and full treatment under the Maryland Medical Protocols for EMS Clinicians protocols. Now, this is what the MOLST looks like. The left page is what would be appropriate to look for the EMS provider. The right page is kind of more for chronic issues. Now, as you come into the house, or into the area where the patient is, where are you going to look for a MOLST? Well, this is where the MOLST is supposed to be put: at the bedside, above the bed, behind the bedroom door, or on the refrigerator. So this is where you look for the MOLST. Now, let's delve in and look at what is on a MOLST. Again, the MOLST form is acceptable for a patient who's in cardiac arrest or respiratory arrest, and the patient is nonverbal and lacks the medical decision-making capability. Clearly, if the patient has a MOLST and they're totally competent, and they say, nope, disregard my MOLST, then of course you disregard the MOLST. And this is for patients without the ability to express their wishes. Now, if you look at the resuscitative status, there's 4 major categories. There's the attempt CPR category. In other words, my MOLST says, give me full resuscitation. Next is the MOLST 1A, which says, hey, don't do chest compressions, but you can intubate me and do everything else. There's the MOLST A2, which says, hey, don't intubate me, no CPR, but do everything else. Then there's the MOLST B, which says, hey, look, don't resuscitate me, don't intubate me, and guess what? Don't even do the complete resuscitation. In other words, just use palliative care. So MOLST B is palliative care. The A2 is intubation, probably no intubation and no ventilation. No intubation and no CPR. The MOLST A1 is no CPR with intubation, and attempt CPR means do everything. Now let's look a little bit more on what palliative care means. If you look, again, here again is our attempt CPR, the MOLST A, which includes intubation, MOLST B excludes intubation, and A2. So again, A1 includes intubation, A2 excludes intubation, MOLST B is palliative care. Palliative care includes what? Let's look. MOLST B includes respiratory. You can open and maintain the airway. You can give oxygen. You can ventilate. You can suction. You can help get the position in comfort. If there's external bleeding, you don't put a new IV in, but you can go ahead and do pressures, tourniquets, standard treatment for blood loss. You can immobilize fractures for patient comfort. For uncontrolled pain, you can help the patient or have the patient take their own medicines. Existing IV lines are totally okay. And you can transport, upon the request of the patient, family, or caregivers, to a specified inpatient hospice facility for pain control, symptom management, or respite care. This is in lieu of transport to a hospital-based emergency department. So in other words, you're not going to the emergency department, you're going to a hospice facility. The one thing that the MOLST describes, again, is the fact that we need to notify law enforcement or medical examiner's office if the medical examiner needs to be notified if the death if the case of death is sudden or unanticipated death that occurs by violence, suicide as a result of an accident, suddenly if the deceased was in apparent good health, or any suspicious or unusual manners for death. So those things are medical examiners. Those things need to be reported to the medical examiner and law enforcement. Okay, and this is the algorithm that is in the guide for the use of MOLST. All right, so what have we said? We've looked at the termination of resuscitation in an adult, and we've looked at termination of resuscitation in a child. We looked at pronouncement of death in the field, and we looked at the DNR MOLST. So let's summarize. First of all, end-of-life decisions are difficult in anybody. It doesn't matter who you are. These are very, very difficult decisions at every level of the medical chain of care. If indeed, as an EMS provider, the patient is found unresponsive, pulseless, and apneic. The next step is to see if there's lividity. If there's lividity, rigor mortis, you can pronounce death at that moment, and you will call law enforcement, and you will signify that the patient has expired. If there's no obvious lividity, signs of death, and then you'll check the MOLST. Is there a MOLST? If there's no MOLST, then you will start resuscitation. And then you'll consider termination of resuscitation if the patient's not pregnant, the patient is less than 18 years old, the patient's not hypothermic or drowned, if it's the patient's medical, if you have 30 minutes of CPR, or if it's blunt trauma, you have 10 minutes of CPR, and while you're looking for irreversible causes. Then, in addition to that, not on the slide, if you're not in asystole, if you're pulsus vitac, BFib, or PEA, and your end tidal is less than 15, then you can terminate resuscitation in the field. The exception is penetrating trauma. Penetrating trauma needs to be transported. Also, a consideration is whether the patient is socially or legally, whether it's socially or legally appropriate not to transport. In other words, not legally in the terms of it's illegal, but in other words, does law enforcement recommend or feel that it's appropriate to transport the patient to, because the scene is an inappropriate place to keep the body. Thank you very much. I'll be glad to answer any questions.
So thank you for a very difficult topic. When you go on these calls and you arrive there, it's always that silent pause when should you or shouldn't you? And it's a difficult decision. I learned in the hospital pretty quick with witness monitored cardiac arrest, the resuscitation rate is very well, hence the importance of citizen CPR. Establish an airway, breathing, and chest compressions. And those patients tend to have a much better outcome. I also learned when patients arrived with CPR in performance that your survival from asystole after 10 minutes was about 0. And that was usually, patients have been worked in the field for anywhere from 15 to 30 to 45 minutes. We would do 10 more minutes and then we would stop. Unless the providers had told us the patient had been in asystole for the last 20 or half hour. So, but it's always a difficult determination, or it's that pause when you get there, especially at a nursing home. When was the last time this person was seen? And then you check, and is there a pulse? Is there not a pulse? You're not sure. Are they warm? Are they not warm? And then most important, is there a MOLST? Now, nursing homes will be good about it, but most people at their house won't unless they're under hospice, making it difficult. Trauma, usually it's pretty obvious, but not always. So this is a very difficult topic. And there's never a right answer, and there's never really a wrong answer. If when in doubt, just start. You can figure it out afterwards, or you can run through the protocols. So, any questions, any comments from anyone?
Does anybody have any stories they want to share of deaths in the field that were, or field deaths that they thought were particularly complicated? Or
I have one comment here. If possible, could you tell what makes it not acceptable to transport for a pediatric patient? Would EMS ever?
one more time? Oh, for peds? Let me go there. Sure.
Obvious death, like homicides.
Oh, when it's not appropriate to transport?
Right.
Well, based on what I'm reading here, really, let's go to peds, for example. It's the let's go look at that for a minute. It's very difficult because everyone at the scene has to agree. Let me go back. Sorry. Everyone at the scene has to agree, according to this, that it's okay not to transport a kid. That's basically what this is. In the judgment of EMS and law enforcement on the scene, is there adequate social and emotional support and safety for civilians and professionals on the scene? And in the judgment of EMS and law enforcement, scene is amendable. You know, so many times in my not as extensive experience as yours, Jeffrey, we've had someone who's died in the house, and then law enforcement officer has to stick around until the coroner comes, right? And I can see from a practical standpoint, the law enforcement article and say officer could say, look, I don't want anybody to stick around. Let's just have them transport to the hospital, and then I don't have to stick around and hang out. I can totally see that. Even
It
though it's not
depends if
the
it's a
best use of
medical or a
resources.
trauma death on that one, because trauma deaths will get investigated by the coroner, but medical, there's a lot more questions.
Right. So it's a complicated issue. I think really what this does is it protects you for terminating resuscitation in the field. But again, complex topic.
So the next question says, I had a stage 4 cancer patient with an unsigned DNR with the POA on the phone not present. The problem you have when you have a POA on the phone not present is, how do you know that the POA and where's their paperwork? So that's a problem. The POA really needs to be present. Or there has to be some, the hospital will demand the paperwork in advance with the POA. Just because somebody says they're the POA doesn't mean they're necessarily the POA. There's paperwork involved with that. If the DNR is not signed, then it's not a valid document. And even for the hospital experiences, an unsigned DNR has no weight. So always a difficult, again, anything that's been properly signed, it's in case, but just because it's been filled out doesn't mean it's been signed. And if it hasn't been signed, it has to be signed by all the parties involved, the provider and the patient, or the patient's power of attorney, for it to be valid. Hospitals and nursing homes might use bracelets to prove that they have one so that they don't keep it at the bedside, and that's okay. The interesting thing becomes is if the patient doesn't have a MULS, but they have a live-in will that the lawyer wrote for them or it was downloaded, they still exist out there. I believe if it's a proper document, we can follow it. The hospital will follow it. But whenever there's a question, anytime there's any question, you can always get on the radio and consult and talk to the ED. But in the last, I guess, 5 to 10 years at this point now, most have become the common document. I haven't seen a live-in will used at a hospital or used outside of the hospital in years, and even within the hospital, they've gone to MULS, or as soon as they get there and they have a live-in will, they create a MULS at that moment for the hospital use. Nursing homes pretty much do it on admission, if indeed there will be one. You can't tell a patient, just because someone's in a nursing home doesn't mean that they have to have a MULS. Not at all. That's a personal decision between the patient, their providers, and their families. But it is certainly not a requirement. Let's see what else in the comments. They said they worked the code because it wasn't signed, which would be the proper thing to do. So you said it wasn't per se safer to transport, but who would trump in that PEDS case where termination of CPR was on the line? But once CPR started, you're going to be involved with consult anyhow. So that's one thing. And then two, for the PEDS patients, again, you're not going to get in trouble if you transport to the hospital once you start. It just doesn't happen. So I hope that answers that question. Again, they're very difficult questions. It's just not cut and dry sometimes. Again, trauma is easier than medical. The question is, are they cool to the touch or are they warm to the touch? If they're warm to the touch, it's probably better if there's no moles to do it. Medical alert tags. Interesting. Medical alert for moles, the moles should be somewhere nearby. A medical alert does allow you that there's an intent there. If they're wearing a bracelet that says DNR A or B. If they're from out of state, they might only have a medical alert tag. They might not have a Maryland moles. Say somebody who's going through the airport or something. What else? The attendance for if you wish to have some CME is located in the chat. Please fill it out. We're still looking for recommendations for some topics as we plan the course out for the year. We've already had some and we're actually working on it. We've already done one of the recommendations. We have obtained a speaker for that already. So we're definitely looking at it. But yeah, what do you want to hear? So does anybody have anything? You can turn your mic on if you'd like. Otherwise, I thank everyone for coming. I thank you, John.
Thank you for the invitation.
So, but this is important, and it's a very difficult topic to talk about. It creates lots of emotion. Just for the reasons you said, everyone's trained to save, but when do you stop?
Thank you, Dr. Sagel.